Rounds. I appreciate all of you joining. We have a superstar interdisciplinary team leading Grand Rounds today, and I'm going to pass it over to Nicole Askren, who's going to introduce the topic and the speakers.
Thanks, Kate. Just making sure everybody can still hear me. Okay, great. Thanks for having us. Good morning, everyone. I know it's bright and early, so thanks for choosing to join us today. Welcome to He Can't Eat That, He'll Choke, Managing Ethical Dilemmas Around Diet Preferences. My name is Nicole Askren, and I am the Assistant Chief of Speech Pathology at the VA Puget Sound Healthcare System. And I also help with our ethics committee, serving as a healthcare ethics consultant. And I'm joined today by my colleagues, Dr. Lisa Vig, who's a geriatrician and palliative care physician, also chair of our VA Puget Sound Healthcare Ethics Committee, as well as Stacy Gwatura, who is a nurse ethicist and palliative nurse practitioner at the University of Maryland Medical Center. So today's presentation will feature a series of case studies that we'll use to try to illustrate some challenges associated with eating and drinking in folks living with dysphagia or swallowing disorders. We suspect that a lot of you have likely experienced some similar cases. Many of you have probably attended maybe discipline-specific didactic lectures on this topic. But today, we're hoping that by bringing a variety of healthcare provider perspectives into one offering, we can sort of simulate how challenging cases like these we're about to introduce can be approached collaboratively through an interdisciplinary support that hopefully amplifies the patient's preferences. Okay, we have no financial or non-financial conflicts to disclose amongst the three of us, and just want to mention that today's content reflects the views of us presenters and not that of the US government or Department of Veterans Affairs. By the end of our talk today, we hope you'll feel more confident by being able to recognize stakeholder perspectives that may be in conflict when faced with dysphagia-related clinical care challenges, be able to describe updates to the literature regarding the utility of diet modifications for the mitigation of swallow safety concerns like aspiration and choking, identify ways in which healthcare providers can approach challenging care decisions, and then we'll also apply some ethics principles to understanding and considering dysphagia-related clinical decision-making. So we'll dive right in with our first case for you all. This is Mr. Hines. He's an 82-year-old male who's been admitted following a very recent stroke. He is a full code, and he's been diagnosed with oropharyngeal dysphagia by his speech pathologist, and a rather restrictive diet, including minced and moist solid foods and mildly thick liquids, has been recommended. And we hear from Mr. Hines. He says, I really want that hot dog and normal coffee like my roommate gets for his lunch. I'm sure you've had similar experiences and cases. So here are some examples of what some likely perspectives of the select stakeholders would be in this case. So, of course, we know what Mr. H wants. He wants to eat normal foods. Maybe the nurse might ask, what will be safest for Mr. Hines so that his health continues to improve? The speech pathologist, we know their perspective. Mr. Hines's oral stage dysphagia places him at risk for choking, and we have proof of aspiration of thin liquids on his swallow study. And then the physician might be asking, what will be most helpful to Mr. Hines's recovery? So with those in mind, I'm going to pass it off to Lisa, who's going to talk us through the ethical dilemma here.
Yeah, and so as you all know, in these cases, we encounter an ethical dilemma where there's sort of tension between stakeholders about what they want. And so in this case, obviously, Mr. Hines' perspective is he wants to eat foods that he wants, that his roommate gets, but that he might aspirate and choke on. And from the team's perspective, they want to promote patient health and safety. Next. And so when we're approaching ethical dilemmas, we often put together an ethics question that we're going to try to answer. And so here's one potential question for this case. So is it ethically justifiable to allow Mr. Hines a regular textured oral diet as he prefers, when he has known oropharyngeal dysphagia that places him at risk for dysphagia-related complications, such as choking and aspiration pneumonia. And so once we have a question, then we often will start assembling the information that we need to answer that question. And that may include things such as medical information, patient preferences, other parties' preferences, and ethics knowledge. And so as we launch into this, we might go and talk to some of the other stakeholders. And so we will do that.
So when I think of how nurses experience ethical dilemmas, I think of it through the lens of all of us having a need for psychological safety in the work that we do. So when the patient is requesting the hot dog and coffee, a nurse is likely to automatically think, do I have the right orders in place already? Do I have the education that I need to provide education to the patient and maybe family about higher risk oral diets? It's necessary to collaborate with speech language pathology and all team members in order to have a shared common goal and shared language when connecting with the patient and family, and when optimizing safety for the patient if they're accepting a higher risk diet. Nursing practice is also shaped by institutional policies, and those policies should really frame nursing practice in ways that are ethically sound and psychologically safe for the nurses. And also, there's the possibility of the nurse having moral distress due to the time that they're spending caring for this patient and family. Next slide, please. So the ANA, or American Nurses Association, has a code of ethics that addresses some of these issues. And it's very clear in enforcing that the recipients of care have the right, morally and legally, to self-determine and to exercise their autonomy. That means that they have the right to accept, refuse, or terminate treatment, and they have the right to do so in an environment that's free of coercion, manipulation, etc. Next slide, please. It is important to notice that we can respect a patient's decisions for themselves without agreeing with them. That goes for all of us. We can support their choices, but we also have a duty to mitigate the potential risk or harm involved in those choices. Next.
Back to me. Thanks, Stacy. So while it's not necessarily the role of the healthcare ethics consultant to provide clinical recommendations, of course, having an understanding of literature that's relevant to a case is certainly helpful. And the speech pathologist would be a stakeholder in this case who'd be likely, hopefully, queried by the healthcare ethics consultant to better understand that perspective. And so I'm going to just provide a little literature update overview here and start by picking on thickened liquids to begin. So there's quite a bit of literature that's been published in the last 25 years or so, exploring various outcomes associated with diet texture modifications as it being used as an intervention for managing oropharyngeal dysphagia. And while this merging of literature is continually being shaped and updating our practices, bottom line up front that is pretty confirmed in practice now is that we know that thicker is not always better. We've learned that thickened liquids generally result in less incidence of aspiration, so number of times maybe somebody's aspirating when they're swallowing. And for many circumstances, this works because thick liquids flows more slowly, hence offering some extra time for the swallow mechanics to protect the airway. But patients still appear to end up with aspiration-related pneumonia in many of these studies and probably maybe situations you've observed in practice. So while it's logical to assume that less incidence of aspiration must equal less aspiration pneumonia, the literature tells us that it doesn't appear that this absolves the risk of developing pneumonia quite like we previously hypothesized. Some researchers suggest that patients with dysphagia are still likely aspirating some of that thickened liquid, And we know that that thick goop in the lungs is hard to expectorate and expel independently. Others have also explored maybe thickening products ingredients used to thicken could potentially exacerbate that issue. And then from a different outcome perspective, thickened liquids may very well reduce incidence of aspiration-related coughing that we can observe at the bedside. And so if simply reducing incidence of swallow-related cough with liquids, no matter the long-term outcome, thick liquids might be very helpful in that case if it improves the patient's comfort and goals are focused on that. And the patient will actually drink them. Most folks don't like them. I thought I'd throw in some additional outcomes that have been explored. This is really a summary. If this is something that interests you, I'm happy to provide a more extensive reference list, although all these references are available at the end. And I'd like to just preface by noting that all of these studies have pretty unique variables like patient demographics, evaluation methods, generally don't offer blanket recommendations, but rather the next couple of slides are just to demonstrate that there's a multitude of factors that have been explored beyond aspiration that can impact recommendations and should be considered when educating stakeholders, especially during an informed consent process. So with liquids, studies have demonstrated that they positively, again, reduce that incidence of tracheal aspiration during swallowing and the clinical presence of coughing, so coughing at the bedside. But note that the absence of coughing with thick liquids is a tricky one. One important study demonstrated that folks who overtly aspirate thin liquids may do so silently, meaning no clinical response when given thick liquids. So just because somebody coughs less with those thicker liquids doesn't mean we've eliminated aspiration. And that's why in many cases your speech pathologist will recommend a swallow study. Negatively, they may impact where medications dissolve in the GI tract, henceforth its bioavailability, although a quite recent systematic review indicates that further testing needs to be done to confirm that, but something to think about. We also know a lot of studies have shown negative impacts on quality of life. I'll highlight a particular one in just a few minutes, a specific one. We also have data that demonstrates both seemingly positive and negative effects of thick liquids on, excuse me, certain aspects of the physiologic swallow events. We know that for some, thick liquids result in more residue of that texture in the oropharynx after the swallow, which then can be eventually aspirated later. GI effects have been cited, things like diarrhea, bloating, others. And then data suggests that the order for thickened liquids contributes to increased incidence of UTIs and dehydration. And that's just because people don't like them, so they drink less. Studies have also determined that provision of thickened liquids is hard on caregivers and it's costly, which could be a particular consideration if this is a recommendation somebody's being sent home with. When it comes to modified solid textures, there's broad agreement that mechanically altered solids like chopping meats, for example, reduces incidence of choking. This is really hasn't been prospectively studied in humans. It's pretty arguably hard to develop an ethical study there. And then folks generally chew less times with modified solids, so we know it reduces chewing burden for some. So those are maybe some positives. On the flip side, some data suggests that there are decreased macronutrients and caloric content in pureed textures. There's also quite a bit of literature with regards to quality of life for solid modifications as well, especially things like social stigma that comes with the receipt of modified textures, especially in a shared space like a dining room of maybe a long-term care facility. A big one that we experience at the institutional level is it's quite costly to modify food textures, requires a lot of training and oversight, adds some caregiver burden, and can be challenging for institutions and caregivers to prepare consistently. So that's another challenge that just adds some burden there. A really important seminal study that was published by Langmore and colleagues in 1998, but still very relevant, helped our field understand that dysphagia alone, including aspiration, so by itself, is not sufficient to cause aspiration pneumonia. Rather, there are health-related risk factors that, when present in addition to the dysphagia, statistically significantly increase risk of developing that pneumonia complication. And these include things like dependency for feeding, dependency for oral care, oral health status, ambulation status, just to name a few. And applying that clinically, this just means that each case, as always, needs to be approached individually. And Doctors Palmer and Padilla developed this really helpful tool that you would potentially see in the speech pathology literature called the BOLUS framework. And I just love that acronym. And while I won't explain it in a ton of depth today, you can take a look at it there on the screen. This figure just illustrates this nice dynamic, intentional approach to diet texture modification, rather than sort of a blanket, you have dysphagia, you need a modified diet type of thing. The authors acknowledge, and I'll just point out here, that this framework lacks consideration of patient preferences, of course, and values. And that's okay. We just need to remind ourselves that patient values is an incredibly important factor. And I'm just going to finish my quick little lit review with a study to demonstrate that. I just think this is a really interesting one. Published in 2016, a group queried 76 patients, and this was a hypothetical study, 76 patients who did not have a swallowing disorder, but they were in a patient situation, and then as well as 75 healthcare staff. Both groups were given 2 thick and liquid samples, one more thick than the other, and they determined that participants would be willing to trade 4 years of a 10-year life expectancy to avoid thickened liquids. And more time was traded, the thicker the liquid. And I'll just read this quote that I think is worth mentioning. Non-compliance, I know we all love that word, non-compliance with thickened liquid recommendation, even if this results in greater risk of complications and death, may be a rational choice for some people. So I find that a pretty compelling conclusion there. And so I just wanted to bring this up and comment that quality of life may be far more important to patients than we think when it comes to food and drink, and possibly more important than presumed safety. One big limitation that I'll pass it on, it did not include folks with dysphagia. So I think that would be an interesting addition, because if you really do have a pretty uncomfortable swallowing disorder, maybe you'd feel otherwise. Off to you, Lisa.
Great. So we've heard a lot about perspectives. We've heard a lot about the literature, codes of ethics, etc. And so I think all of us would argue that in approaching this situation, we need to use an informed consent lens, just like someone would be giving consent for something else that happens in a healthcare setting. Next. And just a reminder, because I can't control myself, that in order for patients to give consent, they need to have decision-making capacity. So I think in some of these cases, there's an additional step that before we allow the patient to consent, we need to make sure that they really are able to do that. Next. And so just a reminder, this comes from our VA's national directive about informed consent, but a reminder, and I'm sure you guys know this, but anyway, if we're going to have an informed consent discussion with a patient, we're going to share the amount of information that a reasonable person would want. We're going to discuss the risks, the benefits, and the alternatives of the various options. And then the last bullet point, we need to remember that patients are free to make their own choices, including choices that we might not think are in their best interests. Next. And so, as a reminder, people with decision-making capacity have the right to make bad choices, right? Have any of us ever made decisions that someone else considered bad, right? I would argue that going hiking with high heels is not a good idea. I also think this teddy bear coat is probably a bad fashion choice, but other people might not agree with that. Next. And this gets at the principle or concept of dignity of risk. And what is that? It is the right to live life in a way someone chooses, even with risk. And I like this definition from Nova Scotia Health, which adds, most older adults want to keep their independence and make their own choices instead of being kept safe. In healthcare, we run into this a lot, where we want to keep the people we're taking care of safe, but they don't always want that.
All right, thank you. And pivoting back to the nursing perspective, I think a lot of people may be unaware that nurses themselves can feel like invisible stakeholders when ethical dilemmas are happening. And when you're caring for the patient and family in such an intimate way, and yet you feel disconnected maybe from some of the decision making that's happening, that can be an additional cause of moral distress for individual nurses and for nurses in units and in departments. So again, I would encourage people to consider involving nurses when possible and with the patient's agreement in capacity evaluations, discussions of care goals. When that can't happen synchronously, make sure there's a warm handoff and communication with the nursing team about the outcomes. Nursing obviously needs to be involved in the plan to mitigate risks whenever a patient is accepting or refusing an intervention where nursing care is going to be directly impacted. And then also thinking proactively about resources that can address moral distress that may occur when nurses or any clinician might disagree with the higher risk choice that's made by a patient or their family. So an example of that could be a peer support service that's staffed by volunteers to speak with clinicians about their moral distress that they're experiencing. EAP, employee assistance programs, is another possibility. Next slide. Again, some strategies around education and communication include bringing the nurse into the informed consent and informed refusal processes, because this will also often involve a patient declining enteral feeding. And so having the nurse part of that discussion whenever possible is really essential to the psychological safety and reducing moral tension for each nurse that gets involved in these scenarios. Having clear communication with the team and clear documentation and appropriate orders for the nurses is really essential. Speech language pathology, when possible, can invite the nurse to the bedside evaluations that occur and discussing the implications of those evaluations. And nurses can always be encouraged to bring issues of moral distress or disagreement to their direct supervisor, their charge nurse, or their unit leader, because we all know, I think we know, that the long-term effects of moral distress include things like burnout, mental health issues, and even leaving the profession. So those things are not insignificant. And one case with ethical dilemmas or moral distress may not do it, but if this is happening repeatedly and not being addressed, that is a larger systematic problem. Next.
Back to me, I believe. Yeah. So in a case like Mr. Hines, we love options, especially as healthcare ethics consultants. Doesn't have to be black and white. Maybe there are some things in the middle, somewhere along the spectrum, that might be useful in such cases. So just some examples for a case like Mr. Hines, maybe regular textured foods, but they are cut by staff and trained caregivers if that's available to them. I think all of us realize staffing can sometimes be an impact on a suggestion like that. But maybe even inviting their own care partners, in this case, maybe a spouse or a loved one who may be visiting, to participate. Maybe there's some environmental supports that might be useful to support a safer swallowing situation. Things like reducing distractions in the environment, which often there are plenty in a hospital setting. Adaptive equipment, hopefully as the speech pathologist working with them, maybe even occupational therapy or other rehabilitation specialists may be able to offer some insight into any adaptive equipment that hasn't been considered. Maybe protocols that are appropriate in certain situations. Some of you may have heard of the Fraser-Free Water Protocol, for example, which combines diligent oral care and opportunities for water in folks who are on very restricted diets. And then, of all things, we have strong literature to support the diligent oral care, or the inclusion of oral care, really as a infection control approach for managing aspiration pneumonia, aside from all the other benefits of good oral health. And I'll refer you to Ashford 2024, who does a really excellent discussion on that topic. But maybe emphasizing that as something that especially care providers like nursing, et cetera, can really help out with to try to minimize that risk as much as possible. So, an approach to Mr. Hines's request. Hopefully somebody along the way has assessed decisional capacity to make this unsafe decision. There's been an informed consent discussion about diet choice, discussing risks, benefits, and maybe some alternatives to the requested diet options. I like the word options. There's been documentation of that discussion. And then there's hopefully been work as an interdisciplinary team, not forgetting our nurse colleagues who are often with the patient most, to develop a care plan that people are comfortable with. And just some take-home messages that really highlight what I just said, but just putting it all together. Is that patients with decisional capacity can make bad decisions. They're bad to us, but they may not be considered bad to them. We engage in and document informed consent discussions around diet choice. And then again, just emphasizing that we work as an interdisciplinary team, hopefully, to develop a care plan that folks are comfortable with. And with that, I'll pass it back over to Stacy.
Okay, so I was really fortunate to be part of a task group, a multidisciplinary group that addressed this issue. And for that hospital, this was really a big shift in culture and practice. So from that task group came some interventions that we would recommend for any other hospital or institution that is considering a shift in the way that they might address higher risk oral diets. So one big thing was proactive multidisciplinary education. The way it was done in my experience was first to roll out the education to the inpatient neurology units, who were seeing a lot of patients with stroke and other cognitive impairment. That education should include the updated research on dysphagia enteral feeding tubes, pluses and minuses and limitations, higher risk oral intake and modified diets. All of those things should be included, but also education around the ethical issues and how we can support patients making higher risk choices when they have the capacity to consent or to refuse. The other system level interventions were interdisciplinary rounding for areas that didn't already have that in place. We also included an order set, which had indications for suction in the room, positioning, having supplemental oxygen available. These were primarily nursing interventions, and the nurses wanted to feel comfortable that they could intervene with the appropriate orders, particularly if there was an aspiration event that required nursing intervention. Our providers actually wanted some standardized documentation around the informed consent for higher risk oral feeding, as well as informed refusal for enteral feeding. If that is something that makes providers and clinicians more comfortable with this process, I think that's a very reasonable thing to provide them with. And then documentation also would include risk mitigation strategies. Time-limited trials are sometimes appropriate ethically. That doesn't mean at the end of a trial we tell someone they can no longer make choices for themselves, but a time-limited trial is a good way to set a time frame for reevaluating the outcome and what is going well, what other interventions may need to be added. And again, I'm going to make a plug that we need a plan to support any clinician who has moral distress around these issues.
All right, so we're going to switch to our next case. We now have Mrs. Nestle. This is an 88-year-old woman who's been admitted to a skilled nursing facility for hospice due to advanced heart failure and breast cancer. She lacks decision-making capacity, and her spouse is her surrogate decision maker. She's receiving comfort cares and has a DNR/DNI code. And she's also been diagnosed with oropharyngeal dysphagia by her speech pathologist, also on a highly restrictive diet, including pureed solids with thin liquids, only administered by a teaspoon or what's called a 5 cc Proval cup. It's in a bolus regulating adaptive cup that only allows 5 cc's out at a time, which you can imagine, that's a really tiny amount. She's also being fed by nursing, so she's a one-to-one feed, as you often will hear colloquially. And her spouse states, I really want her to enjoy her last days. Eating has always brought her so much joy. Please feed her regular foods. I don't want her to eat baby food at the end of her life. So the stakeholders the perspectives of the stakeholders we might observe here. We know how Mr. N feels. He's already shared he wants his wife to enjoy foods that she historically loved. The nurse might ask what will be safest for Mrs. Nestle so she doesn't choke on food that we've given her. The speech pathologist might say, remind folks Mrs. Nestle's oral stage dysphagia places her at risk for choking, and she overtly coughs when drinking too much thin liquid at once. And then the physician might ask, what can we do to promote Mrs. Nestle's quality at the end of her life? Back to you, Lisa.
So here we have yet another ethical dilemma around a similar issue. In this case, the tension is between what the surrogate is requesting and what the team feels comfortable providing, right? So we have the surrogate saying he doesn't want his wife to be fed baby food and wants her to be fed foods that bring her joy as she approaches the end of life. And on the other side, we have the team's perspective of wanting to promote the patient's quality of life, but they also want to keep her safe. And so the ethics question we might come up with for this case is that given that Mrs. Nestle is receiving hospice care with a goal to be comfortable, she has been found to have dysphagia, and her legal surrogate wants nursing to feed her a regular diet, what are the ethically justifiable options around feeding her? And so in this case, too, we would next assemble this information, talk to the different stakeholders, look at the literature, etc. So let's launch into that.
All right. So a lot of nurses are going to want to know, am I required to feed someone what I consider to be an unsafe diet? And I think word choice is very important here. And I would suggest maybe even using the phrase higher risk, as I've been trying to use. So we do tend to think in black and white ways sometimes, but we also know there's a spectrum of risk. And we can't always predict the outcome of our patients taking a risk, okay? So there's no easy answer to that. In some ways, you can say the nurse has a moral obligation to promote his or her patient's safety and to act in ways that are in line with their professional standards of practice. At the same time, that obligation does not change the fact that they have a duty to the patient and to understand and incorporate the perspectives and values of the person who's speaking on behalf of that patient. But it can feel very different to nurses and maybe to all of us if it's not the patient expressing their own choice and taking that risk for themselves versus a surrogate decision maker or healthcare agent making a higher risk choice on behalf of someone else. So the ethical principles here, again, substituted judgment. There's probably no one better than the patient's spouse to speak about what her values and her choices might be. The best interest, if we know that our patient here has a terminal or end stage condition, perhaps the best that can be done for her isn't the same as the best that we could do for a patient who has a different prognosis. And then I like to talk down about consequentialism a little bit and ethics, just to remind us all to have a little bit of humility. Nurses, doctors, etc. We know that risk exists, but we can't predict the outcome for one individual. So even though we have some discomfort, sometimes it's ethically appropriate to work through that discomfort based on patient values. And again, my plug for moral distress. Have a plan so that we're not reacting when the distress, perhaps of one nurse or one tech, extends to an entire unit or department. It is much better to approach this proactively. Okay. And waivers of liability. I want to mention that this was brought up in the task force I was on previously. There were people that were part of the task force that felt strongly that the patient or family should sign some sort of waiver absolving the hospital and the clinical team of any liability if there was an adverse event that followed a patient having a higher risk oral diet. It is not generally seen favorably by a court. It may not be enforceable. And oral intake is not exceptional per se from an ethical perspective versus other interventions. So if a patient or family declines anticoagulation for some reason, the patient's a high fall risk, we document that decision, okay? But it's not that we would ask that patient or family to sign a waiver of liability. Similarly, we wouldn't do so in this case. We document the informed consent for the treatment plan. If there was refusal of enteral feeding, we document the risks and benefits that we discussed, and the waiver of liability should really not be a factor here. One other thing to mention is that a lot of providers felt very strongly also that any patient accepting a higher risk oral diet should not have a full code status ordered. So I will say the ethical answer to that is we cannot use a patient's code status to try to coerce a decision regarding their feeding and their oral intake. There are nuances to that, but there should not be a hospital policy that tries to enforce a specific code status tied to someone's choice to have a higher risk oral diet. All right, and then the context matters. Again, have a plan for educating about the nuances ethically for a patient with or without capacity. Like I said, discussing substituted judgment and best interest principles and how they apply to that specific patient. Patient requests versus the requests of a surrogate decision maker or healthcare agent. It's also appropriate to let the patient or family or both know that no one is going to force feed, because in addition to concerns about aspiration, they may have natural concerns about someone meeting their nutritional requirements, and it should be made clear in advance that no clinical team member will be forcing a patient to eat any specific amount. And again, it is appropriate to discuss code status and goals of care for a lot of these patients. That's part of the informed consent process. That does not mean that every single one of these patients requires a palliative or an ethics consultation. There will be cases with nuances that do require that, but it doesn't have to be routine once the institution as a whole develops policies, procedures, supports, and a comfort level with these types of interventions that we're discussing.
So in this case, one way to do our ethical analysis is to sort of lay things out, look at our options, and look at the consequences of those options on the different stakeholders. So over on the left, if we decide to continue the modified diet, what does that mean for everyone? Well, there will be a somewhat reduced risk of aspiration and choking. But we may reduce the patient's quality of life as she approaches the end of life, and we are basically disregarding the legal surrogate's input. On the other side, if we provide the regular diet, there will be a somewhat increased risk of aspiration and choking that hopefully has been discussed and documented. It's going to honor the patient's goal to maximize the quality of life, and it's going to honor the legal surrogate's input.
And a quick moment for McCann and colleagues, 1994. Some of you may be familiar with this study. One of a few prospective studies that explored how terminally ill patients, specifically with cancer, were feeling at end of life when it came to hunger and thirst. And what they found was that a majority of the folks they queried don't necessarily experience that. Really small amounts of water and oral care seem to satisfy any sensation of thirst, for example, and then really small amounts of food, again, not trying to meet any type of nutritional goal, really helped folks feel more comfortable. I'll read this one helpful, I think, worthwhile quote. Food and fluid administration beyond the specific requests of a patient may play really a minimal role in providing comfort to terminally ill patients. And so I know in my practice, I'm sure the same in all of yours, I really feel that knowledge is power. So sometimes just sharing that information with family during these educational moments, these informed consent discussions can be quite powerful and helpful to really relieve that burden from surrogates like Mr. Nestle in this case. So, do I have to feed this Mrs. Nestle something she could choke on? Hopefully, folks watching feel comfortable knowing that no, we don't have to force anyone to feed, especially our nursing colleagues, patients that they foresee as higher risk diets. There are options. Again, back to the options. A really wonderful article by O'Keefe and colleagues 2023, worth a read if you have a chance. They offer some quotations that maybe could be offered in situations like this. For example, no, I won't administer food of a size or at a speed that will clearly be dangerous for you, but I'll cut up this large piece of steak and just give you the next piece when you've swallowed this one. So maybe there's we call that careful hand feeding. There's some compromise. And then maybe another compromise might be nursing will feed what maybe has been recommended by the speech pathologist or whoever. And then the spouse, maybe, again, we talked about maybe a care partner maybe provides the higher risk items. Just an option to think about, so we're not so black and white about things like this. So the take-home messages for Mrs. Nestle and others. Patients at end of life may want an oral diet texture or their surrogate in their place that is unsafe, or I really like the phrase as well, higher risk. They may want nothing at all, or just some simple measures to increase oral comfort. I'll refer you to that McCann study if you want to read more on that. A patient's legal decision maker uses substituted judgment to make decisions that the patient would have made. And nursing staff should not be forced to feed if they feel it is unsafe to do so. So just 3 little takeaways there. So that is the content that we have prepared for all of you. We do have a little bit of time left, so I know we welcome questions or comments. And yes, we're absolutely glad to get you a PDF of these slides, so you'll have this reference list as well. And I'll just end it here on the evaluation. If you have an opportunity to scan that QR code, we welcome your feedback.
Thank you so very much for that fantastic presentation. If anyone has questions, please feel free to unmute. And if for some reason you're not able to, you can put the question in the chat.
I have a question, but it's related to feeding tubes, which I know is sort of off topic, but so maybe I'll wait to see if there's other questions related specifically to oral feeding. Okay. Should I go ahead?
Go ahead, May.
That was outstanding. One of the things I've seen is that everyone appreciates that NG tubes, PEG tubes, etc., have minimal benefit and all that literature. But now, the last time I was on medicine, I've seen patients come back with GJ tubes with the note saying this will solve all of the concerns about the risk of these interventions in mitigating aspiration pneumonia, etc. I know this is off topic, but am I seeing something that evolved naturally or has a database? Because I couldn't find the rationale. But our last 3 patients who went for G tubes, all who are older adults who had potentially remediable issues with their swallow, stroke, head trauma, etc., came back with these tubes, which I think for nursing is, just add to their workload. They looked very complicated. Oh, and someone else is seeing that too. Yes. I know it's okay. Thank you. Any light you could shed on that? Amisha is saying she's seeing that too.
I apologize. I was the teensiest bit distracted looking for a specific reference for one of our audience members. But the question was about feeding tubes in folks with presumably rehabilitatable dysphagia.
Correct. And them coming back because of the concern about traditional G tubes with GJ tubes. And where did that evolve? And it's not as if I had written it that way. It was just the decision making that was by IR in this case.
So you're just seeing more GJ tubes. I'm sorry, was that the?
Yes. And Amisha, hi Amisha, is saying that she's seeing the same over at her institution. So this idea that if we advance our technology, all of your concerns about these tubes will be mitigated. And I'm worried, of course, that this will evolve to patients who really shouldn't have this PEG tubes put in at all. But
sure.
Yeah.
I haven't seen that personally, but I'm a little, I'm in my little VA bubble. We're a little short on IR anyway right now. And so I'm not exactly sure where that's coming from. I don't think I have any educated response for that. And I don't know, I know, certainly with G tubes, there's concern, like we know that it doesn't eliminate the risk of aspiration, especially if they have what we call postprandial aspiration. So they're, reflux or aspirating their reflux contents. I don't know if that's completely mitigated by a GJ tube. I don't have a good repertoire of knowledge on that to provide a good response, but that is certainly an interesting observation.
Yeah, I'll add that I don't have a literature-based response. I will say anecdotally, I can imagine it happening just because of experience with people who started with a G tube. There was some indication to progress to a GJ tube thereafter. But I think it really deserves more dialogue if there's literature that I'm not aware of, because in addition to not eliminating the potential for aspiration, it doesn't change the potential for any other iatrogenic complications, such as using physical or chemical restraints, increased agitation, self-removal of the tube, increased stool burden for the patient, which can lead to skin breakdown. Those are all potential complications that I don't believe there's any reason to think that wouldn't happen just as often with a GJ versus a standard G tube. So it does sound like there's some discussion that needs to happen about why that's occurring and if there's a legitimate evidence base for it, and if patients and families are getting the appropriate education around the time of consent.
I would certainly support what Wayne just mentioned. Making people NPO, and doing whatever intervention is decided upon for their nutrition does not eliminate risk of aspiration. So certainly that's across the board. Should be part of the G-tube education, that just because we're making somebody NPO, and hopefully there's a discussion about that too, and recommending a G-tube does not eliminate their risk for aspiration pneumonia, because aspiration pneumonia, the source of it is really the bacteria within the saliva itself. So, people can still aspirate that. Unfortunately, we typically observe, especially in long-term care environments, that when somebody gets a feeding tube, other things like oral care sometimes declines as well, which is just the absolute most important thing of all to try to minimize or mitigate that risk. I prefer the word minimize because we can never fully mitigate the risk of aspiration pneumonia. Unless you get a laryngectomy, that's the only way, and that's pretty invasive. But we have some pretty egregious cases where that is the option.
Yeah, I'll add that in my previous task force experience, that was education that all of us needed to share in, whether it was nursing, GI, IR, even surgery services, because nurses are talking to patients and families, and anyone who's performing this actual procedure, in addition to their informed consent, should have some idea about potential long-term ramifications. So especially for people who end up in an institutional setting, things like spending less time socializing with people because of being fed through a tube, especially if it's continuous versus bolus feeding. That's borne out in literature too. And so it is really important that everybody who's part of that clinical team around that subject get the same education, so that we're giving a unified message and an accurate, transparent message to patients and families who are making these tough choices.
I find that it's relatively common to see this conversation happen without the next part of the conversation of what we're going to do, practically speaking, when an aspiration event occurs. And then people are scrambling at that moment, like, what do we do? Are we treating with antibiotics? Are we transferring to the ICU? And I was wondering if you could provide some best practice recommendations for the folks listening about strategies to approach that conversation and documentation for that part of this process.
Yeah, sure. I think it's very reasonable. Again, if this represents a shift in practice and culture, I think it's very reasonable to have a multidisciplinary task force to even write a policy and procedure that applies to most patients. It's not going to apply to every single patient, but in someone accepting a higher risk oral diet, it's probably appropriate to utilize an order set that addresses things like having suction and oxygen. Those are palliative or potentially palliative interventions, and that should really be the standard of care, I think. But this is like any other goals of care discussion, which is why I mentioned the possibility of a time-limited trial. The time-limited trial can be offered to a patient and family to say, we will attempt this higher risk diet for X number of days or until we have an adverse event. Either of those things is a time and a place for us to reevaluate, okay? And again, having proactive conversations about how staff is going to deal with the adverse event itself. In practical terms, that's part of the care goals conversation that's documented according to the institutional standard, but also in terms of moral distress that could result from it. Because my worry is that not having that plan, how do we address this with a debriefing after the event or whatever, not having a plan kind of means that we can return to business as usual and allow the challenges that have built up for people with moral distress, ethical tension, et cetera, those accumulate over time. So making it part of the culture and the standard of care to address the psychological component of this for the clinical team is important too. But I think a policy and procedure with input from all the stakeholders can really be protective for everyone's psychological safety around this.
We're getting to 9 o'clock, so I think we will wrap up. This was phenomenal. I really appreciate this presentation. We all learned a lot, and it was really helpful to hear your perspectives and weaving those all together. Just really fantastic. So everyone, please fill out your evaluation and document how wonderful this presentation was. Thank you for taking the time today to teach us and answer our questions. Really, really wonderful. Thank you.
Thanks for having us.